Thank you for that very nice introduction of me, at least. Thank you very much. Flattering also. So let us talk about Pneumocystis jitovecii in the kidney transplant recipient. Jitovecii is the new name, as Dr. Naina sir was telling us. Yeah. So the first thing is, like sir was saying, it was found by Antonio Carini in Brazil. He identified a new species, what was then thought to be a protozoan, and was named Pneumocystis carini in his honor. By actually, it was not. He found the organism, sent the samples to France, and they found out that this is a so-called protozoan, and then they named it in his honor. But only in the 1980s, molecular biology confirmed its fungal nature and reclassified it as a fungus. And at that time, it was believed to be responsible for severe pneumonia in AIDS. But the human species was not the same, and then it was renamed as P. jitovecii after the Czech parasitologist, like sir was saying. He linked it with neonatal lung infection. So this is the organism, and you can see that it has got both sexual as well as asexual forms. Both forms are present in the same host. And you can see that some of these terms like pre-cyst, early cyst, maturation, the trophic form, all that resembles that of the naming like that of the protozoan, but actually it is a fungus. It is not a protozoan. And it has got a cell wall which is similar to the fungus also. And that's why, as we are going to see, that beta-D-glucan plays an important part in the identification of this organism. So in the kidney transplant recipient, what about this organism? Is that so in the previous days when they were not giving prophylaxis, almost 15% of them developed PCP pneumonia. Now you can call it PJP or PCP. When you say PJP, you can say it's a Pneumocystis jitovecii pneumonia, but otherwise you can say Pneumocystis pneumonia. So PCP also works. So it was about 15%, but even with prophylaxis, about 0.4 to 2.2%. So it is not a very infection that you can ignore completely. The lowest rates are in kidney transplant, but the highest in, obviously, for a lung or heart-lung transplant. Of course, they are more prone to this type of infection. And usually it occurs within the first 1 to 6 months. But nowadays you see a late onset variant, which occurs after 6 months. This is more severe. It usually requires ICU care and higher mortality. Of course, that's possibly because these people are not on prophylaxis at that time. And when they develop the infection, they can have a very serious infection. And there have been multiple places where clusters have been reported. And these clusters point to a human-to-human transmission. And this was initially reported in some clusters from US and others, but there have been clusters reported from India also in the Indian Journal of Nephrology. And what are the risk factors? So you know that the most important risk factor for this is the intensity of immunosuppression. So it may be an ATG induction or maybe, but the most important thing is the higher dose of steroids. In fact, in all conditions where you're giving high dose of steroids, you're supposed to give prophylaxis because the steroids are the number one factor which causes increased incidence of PCP pneumonia. Of course, that's why rejection episodes are more likely to associate PCP pneumonia because again, you're going to use IV steroids, which are more toxic, which are more immunosuppressive, and which predispose to PCP pneumonia. Lymphopenia is another situation. CMV co-infection. CMV is an organism which invites other organisms to infect along with it. So you must always be careful when there is a CMV infection. You must look for other co-infections along with it. ABO incompatible transplant is associated with more PCP, but that's again because the intensity of immunosuppression is probably higher. And after discontinuation prophylaxis, especially if you are giving any higher dose of any immunosuppression at that time, then it can cause an increased incidence of PCP at that time. So what are the clinical features? Now, that is the key thing, how to identify this clinically. So initial presentations in the old days was a severe respiratory failure following a fever and dry cough. But nowadays, because we find it out relatively earlier, the severe respiratory symptoms are less common and they're less severe symptoms. Usually it starts with fever and the onset is usually subtle. There's not much of breathlessness initially. But then there's a dry cough and then some breathlessness starts. And that's the point in which we suspect that it may be a PJP. The symptoms are usually out of proportion to the findings as well as radiologically. Even a normal chest X-ray can be seen initially. But what's important is that all patients will develop hypoxia at rest or mild rest. It happens over a period of time. And that is the point at which you have to immediately start treatment or you're going to lose that patient. So what about the laboratory findings? The counts may be normal. Neutrophilia is usually seen, but of course that is very non-specific. You may find no neutrophilia also. CRP and ESR may or may not be elevated, so it's not usually contributory. If you do a procalcitonin, usually it is not very high, so it will not also be contributory. So none of the common factors which you use to identify a bacterial infection will help us in this fungus infection. Now, LDH elevation with pulmonary infiltrates is a characteristic. So LDH is always more than 300 in this and very useful But this factor is more useful in HIV patients because especially in transplant recipients, there are multiple causes of LDH elevation. So it may not be that useful in transplant recipients. But the more important thing is a beta-D glucan. Beta-D glucan is a component of the fungal cell wall, and it is elevated in the serum in these patients. So an elevated BDG plus lung infiltrate should look for molecular evidence of PJP. So that is an important key. So you have a patient who presents with a mild febrile illness, respiratory symptoms with some breathlessness, and you have elevated BDG and lung infiltrates, and this is almost very typical of a PJP. Of course, a lot of lung infection present like that. And you can see that this is what happened. Now, you can see an early X-ray in patient with PJP, and you can see a little bit of infiltrates here. But you can see what happens after 24 hours, the X-ray has become like this. And that's a progression that occurs so fast in these patients. And early on, you may not get this on the X-ray, but you may get CT findings. So this is what CT looks like. And you can see a lot of ground glassing, which is present in all these places in this. So that is the PCP finding. But the important key thing here is the staining for PCP in the BAL. So BAL is the usual thing that you use to stain, but you can also use an induced sputum by saline nebulization. And here you can see this is a GMSA stain. This is a common stain just used in GMSA. You can see the cysts along with some intracellular cystic inclusions. That's what you can find. And when you stain with IF, you get an apple green birefringence. So you can see those typical shapes of these cystic organisms in this field. And this is the Gomori silver stain, which Sir had already shown you. And you can see that crushed ping pong balls. You can see that here and here. These are the crushed ping pong ball appearance. So as if a table tennis ball is crushed. That's what it looks like. And how do you identify? In HIV, in more than 50 to almost 90%, you can get specimen staining with fluorescent dyes or other stains. So you can see that either with the Gomori silver or with the GMSA or with an immunofluorescence staining, you will get almost 90% possibility. You have a lot of organisms in this. But in solid organ transplant, the number of organisms, the burden of organisms is much lower. So you may not get such a staining. It may be only around 50%, less than 50% who you get by staining. So usually you stain on a BAL or induced sputum. But you can do a PCR on this, and PCR can improve the yield by about 10%. So from 50% to about 60%. So you can do it on upper respiratory samples also, but here colonization is common. So you can get just because it is present, you cannot say that there's an infection by PJP. So that's a problem. So that's why you look for other assays. And one of the important things, like I said, is beta-D glucan. The serum assay has got a good sensitivity, but the important thing is the high negative predictive value. So if it is negative, then it's very unlikely that this is a PJP infection. And the cutoffs, so you can use a lower cutoff for 31, but generally most people use the same cutoff as for Canada, 80 picogram per liter. And what we find in our things is that generally the cutoff of 80 works very well, and the levels are much higher than this. But again, they can have false positives. Pseudomonas organism infection can cause false positives. IVIG infusions, even giving piperacillin tazobactam can cause a false positive beta-D glucan assay. So that's one of the important things you have to keep in mind. So how do you do a definitive diagnosis? So definitive diagnosis, you can use a sputum or BAL specimen for microbiological assays. BAL is better, but induced sputum is easier to obtain. So, but yield is lesser in induced sputum, yield is better in the BAL. So if you can do a BAL, the patient is intubated, ventilated, then BAL is definitely an option. Otherwise, you can use the induced sputum to obtain this. And about 40 to 50%, you will get a positive stain. And the rest you can do a PCR. That's why you can do a PCR and those things. Now, we can do a lung biopsy, but it's not performed routinely because of the morbidity associated with lung biopsy. But that is another option which can be there if you don't get anything on this. The specimen can be stained with GMSA, which is actually the gold, the Gomori stain or the GMSA stain, which are both. Actually, the Gomori is the gold standard. But fluorescent dyes gives equally good results. And qPCR is always there to help us. And now you have a new thing known as a metagenomic NGS, which is done in blood. So metagenomic NGS is what you do in it. You take the blood and do an entire genetic screen of that. You get all the genetic material which is present with that. And from there you deduct which is PJP, this thing. And sensitivity is almost 100% for this, specificity 95%. But you can get false positives and false negatives. So that is there, unfortunately. But this may be the test in the future, a metagenomic NGS. And that is actually a confirmatory diagnosis, definitive diagnosis, but you have a presumptive diagnosis sometimes, which you have to, especially in patients with solid organ transplants, you may not be able to make a definitive diagnosis. So in that case, you do a presumptive diagnosis. So in these cases, you use a clinical diagnosis, radiological diagnosis, and markers such as LDH and BDG. And based on that, you can make a fairly good presumptive diagnosis of PJP. And use a combination of all tests, because you can get infiltrative lung disease in multiple organisms, but you must be quite sure that this could be a PJP rather than others before. But anyway, you have to start treatment fast. That's the important thing. And with that, we come to the management. And treatment, like I said, should start with the presumptive diagnosis. You should not wait for confirmation, because time is of the essence. The earlier you start treatment, the more likely that you are going to treat the patient successfully. Patient on ventilator, the chance of recovery is much, much less. First line treatment is cotrimoxazole. The dose is 15 to 20 milligram per kilogram per day. Now, seeing that one tablet of double strength contains 160 milligram TMP, you need to give 2 tablets 3 times a day at least, or 4 times a day if the patient is bigger. So in order to make it count. So that's a very big dose of cotrimoxazole in these patients. And for severe cases where there is oral absorption is a problem, you can give IV cotrimoxazole. It's available and it can be given in similar doses. The dose is to be adjusted for renal dysfunction, but there is no dose adjustment above GFR 30. But if the GFR is 15 to 30, you give half dose. If the GFR is less than 15, you give quarter dose. If the patient is on dialysis, then on the dialysis days, you can give the dose after dialysis, because there is about 40 to 50% clearance by a standard low flux membrane. So that is there. And those are the doses you use, but it's important to use these doses because 2 tablets TID is the adult dose for these patients. Now, the problem is that some patients have a history of severe allergy in the past, especially Stevens-Johnson syndrome. In those patients, you should not be using. If there is a mild allergy, you can do desensitization. But I think desensitization practically is quite difficult, because you have to give smaller doses, bigger doses, and then come to it. And by the time the patient may be too late to start the treatment. But it has been suggested in the literature. We have not done it and cannot comment on that further. Hyperkalemia definitely is a problem, especially in patients with renal dysfunction and older patients. So we have to be monitoring the potassium regularly in these patients, probably twice a day initially at least. And in higher doses, they can develop neurological symptoms, they can develop tremors, they can develop abnormal movements, and they can develop altered sensorium and delirium. These are all seen with the higher doses of this thing. But you may have to continue the doses despite these symptoms if the patient is really having a severe PJP. Suppose you cannot use, you can use alternative agents. Mild to moderate disease, the drug of choice is Jitovecii 750 milligram twice daily. Jitovecii is not available in India, so you cannot use that. But you can use, if you sulfur allergy, you can use TMP with dapsone. So just use trimethoprim, 15 milligram per kilogram per day. Trimethoprim is available as 200 milligram tablets. So you may have to give quite a high dose for that. Sorry, 100 milligram tablets, not 200 milligram tablets. And dapsone can be given 100 milligram OD along with this. And the next choice is primaquine plus clindamycin. So that is another option which can be given in others. And for severe disease, you can do IV pentamidine. You must remember the IV pentamidine is a very toxic drug. It can cause hypoglycemia, hypotension, nephrotoxicity, and even pancreatitis. So the treatment may be worse than the original disease. So that's one of the problems with IV pentamidine. It was used a long time in HIV earlier, but nowadays we don't use that much. So the other alternative severe disease, again, primaquine plus clindamycin, is the rescue therapy if TMP SMX fails. Steroids are to be given if there is a PaO2 less than 70 or a saturation less than 92 or an A by, that is alveolar arterial oxygen difference more than 30, in that more than 35. So in those patients, we should be giving steroids. And supposing a patient is not having these parameters, but subsequently worsen, again, you should start steroids. The dose of steroids, prednisolone 40 milligram BD or IV methylprednisolone 30 milligram BD. So you give BD for 5 days, OD for 5 days, and then 20 milligram OD for 11 days and stop. So that means around 21 days therapy. That's what you are giving steroids. But you should not be using for mild to moderate disease. But the patient is already on steroids, you can continue with stress doses. That is, say the patient will be on 5 milligram prednisolone. If the severe disease, you can give these doses. But if there's milder disease, you can give just 7.5 or 10 milligram per day to cover the stress dosing of steroids for that time being. How long to give? 21 days is suggested by recommendations, but the duration was derived from trials on HIV patients where shorter duration of therapy led to relapses. And you should know that by 7th day of treatment, you should have improvement. If there is no improvement by then you should look for other infections. And if there is no other infection, you should look for treatment failure. You must remember that this is a patient who is immunosuppressed. They may have PJP, they may have associated CMV, they may have other lung infections, they may have other bacterial infections, and all these should be covered. So you should be able to treat for everything by making sure that nothing else is present. So if it's a treatment failure, you can change to clindamycin primaquine regimen. And the patient has clindamycin primaquine, you can desensitize and switch over to TMP SMX regimen. And if it is failing an IV TMP SMX, then you can switch to IV clindamycin and oral primaquine. So these are the options that you have, but mostly it is a 2-drug option. Either you have Septran or you have clindamycin primaquine. So those are two things which are available. Then intubate and ventilate based on standard indications. But in ventilation, you must remember that you must use low tidal volumes and plateau pressures because these people are higher risk for pneumothorax. And even before ventilation, dyspnea may be pneumothorax, because pneumothorax is a common accompaniment of PJP pneumonia. We should look for vital signs. LFT should be monitored because you're giving a lot of toxic drugs. Of course, creatinine, because these drugs can cause renal failure. Electrolytes, like I said earlier, and hypoglycemia, especially if you're using pentamidine. And you should maintain proper infection control practices because clustering of case possible, you may transmit from one patient to the other and the whole ICU can become infected with PJP. Outcome is mortality without treatment is almost 100%. They will almost invariably die. But with proper treatment, it's about 35 to 50%. So even with proper treatment, the mortality is quite high. And if the patient on ventilator, the mortality is nearly 70%, these patients. And that is unfortunately true. Solid organ transplant patients do worse. Poor prognostic factors are delay in intubation, prolonged mechanical, and presence of pneumothorax is an independent factor for mortality. So pneumothorax not only have to look out for, but if it occurs, you'll be sure that this patient is not going to have a good outcome. So what about prophylaxis? So after treatment, you should give secondary prophylaxis to all patients as long as needed. So as long as patients immunosuppressed. So maybe for 1 or 2 years, you may need to continue secondary prophylaxis. And for all transplant patients, you must give primary prophylaxis. The KDIGO 2009 recommends 6 months for, and AST along with the American Society of Transplant, along with the Infectious Disease Community of Practice Guidelines in 2019, they advise 6 to 12 months. So not just 6 months alone. Usually, I think most transplant units give for 6 to 12 months, depending on their practices. And if you have a rejection you're treating, you should give for another 6 months after treating the rejection. That's very important. You should not forget that. So the drug of choice for treatment is one double strength thrice weekly or daily, or one single strength tablet daily. That is the treatment. So normally, I think most of us give thrice weekly or alternate days. Alternative is dapsone 100 mg body, but dapsone has got its own set of problems, so it may not be good. You have to monitor hemoglobin and should not give for patients with G6PD deficiency, etc. Atavacone, another option, but then it is not available in India, so we will not talk about that. And to conclude, PCP or PJP pneumonia is a serious respiratory infections in kidney transplant recipients and a high mortality even if treated. It occurs usually less than 6 months after kidney transplant. It clinically presents with fever and breathlessness and progressive lung infiltrate. So these are the key is to identify it before the progressive lung infiltrates occur. And diagnose based on CT, LDH with BDG and BAL staining or PCR in the representative sample, which may be a induced sputum or a BAL. The survival depends on early treatment based on the presumptive diagnosis. So by the time you have presumptive diagnosis, you should be able to start treatment, and high dose TMP SMX is the treatment of choice. And prevention is the key. Universal prophylaxis for at least 6 months after transplant is the important thing. So this is the first part of my presentation, and the second part is mostly from our infectious disease team. They gave me the experience, and this is, of course, they have the same thing, proven PJP and probable PJP based on what we have said. And you can see that we have used the cutoff of 80 picogram of per ml of BDG or a positive PCR assay. So these are the things which I have used as an inclusion criteria for diagnosis. And you can see we had 59 patients in the last 5 years, and out of them, most of them were male, and the median age is around 53. And diagnosis was based on a positive PCR in 29 patients and a BDG more than 80 with clinical and radiological features in 30. So you can see that almost 50% of them had a presumptive diagnosis, only 29% had a definitive diagnosis in these patients. So that's the key message here. You should be able to start treatment just based on a presumptive diagnosis, because you're not going to get a positive diagnosis in all. And you can see the BDG more than 80 was present in 43 patients. And this is the BDG less than 80 category, 5 patients had, and not done in 12 patients. And the median BDG was 200 and almost 300. So you can see that using a cutoff of 80 worked very well in our patients. So I don't think we need to have a lower cutoff. And the most important cause was chronic steroid use. So, and SOTs for only 5 patients, solid organ transplants. And the prophylaxis, now this is the key, is that there was an indication for prophylaxis in 39 patients, but 28 patients did not receive prophylaxis. So these 28 patients was probably due to the lack of prophylaxis that they developed this infection. And of these, 17 patients were on chronic steroid use. And you can see that the most important symptom was dyspnea and hypoxemia. So these were the key symptoms, and the findings of crepitations and these were present in almost 73% of patients. And I say the most important, all these things are normal. If you look at count or TLC or ALC or ANC and platelet count, etc. The only thing important is the LDH, the the average value of LDH was 589 in these patients. So definitely LDH was elevated in all these patients, and creatinine was mostly normal. And you can see CT finding, the most important CT finding was GGOs, which present in almost 90% of patients. 49 out of 59 had GGOs. And one of the representative GGOs is shown here. You can see this is a mild GGO present only in these areas, little bit present here. And you can look at this one, is a much more extensive GGOs present in most of the lung, including all these portions. And you can see that this has gone into a consolidation phase. You can see consolidation with the air bronchogram in these areas. And this is a highly diffuse presentation. The entire lung is affected. This patient is not going to make it because it's whatever you do. And treatment, you can see that 93% were treated with TMP-SMX and 21% were treated with clindamycin and primapine. And steroids were given in almost 90%, supplemental oxygen in 83%, and ventilation was required in 37 patients. And you can see that about 30% died. This is our data showed 30% died. So that's the average 30 to 50% mortality. So compared to the literature, we are at the lower end of the range. And you can see out of these 5 patients had solid organ transplants, and in them the result was 2 out of 5 survived. Only 2 out of 5 survived. 66% actually died. So in solid organ transplant, this is more severe, and many patients die. So that is my presentation. Thank you.